Welcome. Good morning, everybody. Welcome to the session on head and neck carcinoma. It promises to be a good session. I'm Paul Thomas. I'm from Royal Brisbane Hospital, and my co-chair, John Kotsikis, is from Greece. Our first speaker today is Professor Hugh Guan, who's come from the Austin, and he's going to talk about an oncologist approach to the management of head and neck cancer. If everyone can turn their phones to silent, please, that would be great. Thanks, Hugh.
Thank you. I'm Hui Gan. I'm a medical oncologist from the Austin Hospital. I'm also the director of the Trial Center at the Austin, and I just want to thank the organizers for inviting me to speak. And I'll just be sketching in from a medical oncologist point of view, sort of an overall high-level view about head and neck cancer, and then lead into the other talks as well. So for this talk, I'm going to be focusing on squamous cell carcinoma of the head and neck in those sites. So we will exclude for this the nasopharyngeal cancers, which I think are obviously a different group of cancers. And also we will not be discussing incidental cancers like cutaneous cancers or lymphomas that just happen to be in the head and neck. So in the Australian data, this would be about the 8th most common cancer in 2017. And I guess there are two groups there that we'll be talking about. So more traditional patients with nicotine and alcohol-related head and neck cancer. But increasingly, HPV obviously is now a vital and important part of head and neck cancer. So I'm just really showing Australian data, which I think is probably similar to much of the Western world. But we can see that head and neck cancer overall is the 8th most common. But it does encompass, as I previously showed, a range of primary sites. And I think that's quite important for many reasons. The prognosis, the biology, the treatment is quite different. So for example, if we start off with head and neck cancer of the lip, you can see that in fact the 5-year survival is very good. And so not surprisingly, in Australia over the last 2 or 3 decades, there hasn't really been any real change in the epidemiology or also the outcomes with that. However, if we look at the other side, which is really where I get to be involved, I haven't seen a lip cancer for a long time. But we can see that if we look at oral cavity, oropharynx, larynx, that you start to see some differences in behavior there. So we can see that if we look at larynx, actually, in Australia, it's gone a little bit backwards of recent times in terms of survival outcomes. And I'll touch on that very briefly later on in my talk. But we also see that the oropharynx, for example, oral cavity oropharynx have improved. And we may have a discussion about whether that's treatment-related, which is probably actually not the main thing, but the change of the epidemiology of head and neck cancer in those sites with HPV disease. So just as a very brief segue, I think human papillomavirus, these are small DNA viruses of which there are some very oncogenic subtypes. And certainly in head and neck cancer, infection with, as in some other cancers, infection with HPV, probably in your younger days, through sexual transmission, is oncogenic and drives oncogenesis through probably pathways which are different from the more traditional carcinogen-based approaches. And certainly in Australia, it upregulates a number of oncogenes. P16 is upregulated, and that's for all the surrogate marker that's used in clinical practice here and also in research. And so why do I focus on this? I think that clearly the biology is different, but also the incidence has been changing. And I think this audience will be very familiar with the fact that, in fact, carcinogen, tobacco-related head and neck cancer has been declining, as you can see on the right-hand side. But on the left-hand side, you can see that, in fact, the incidence of HPV-related, particularly oropharyngeal cancers, have been increasing. And very clearly, the biology of these HPV-driven cancers is different. They are younger people. The patients are younger. So they're said to be more males. I seem to see more of a mix. And the high end stage, the higher end stage compared to the non-HPV is all well recognized. But I think most importantly, obviously, is the different prognosis and response to treatment of these patients. This is the paper in the New England from quite a while back, but Dr. Ang looking, this was an analysis of a randomized study. The primary question had been about radiation fractionation. And I stress that this was randomized between radiation fractionation, accelerated fractionation and normal fractionation, but with high dose cisplatin, and I'm going to come back to that. So this was with our conventional cisplatin, 100 milligrams per meter squared, 3 times during radiotherapy. And you can see that if we look at the outcomes in HPV positive versus HPV negative, that there's significantly better outcomes in the HPV positive. So your 3-year survival improves from 57% to 82%. And that's improvements, but definitely local regional control, some also as well in distant disease. So this then leads to questions about how do we treat these patients, de-escalation, and I'm going to touch on that. But clearly, in everything that we do, I feel that we need to be very cognizant of the fact that are we dealing with an HPV positive population or an HPV negative population? Now, in the clinic, this is what helps me, and I think this is very useful, is that there's probably, there's still an intersection of HPV and smoking. I think smoking is still very important. And I think that HPV disease can be further stratified into, I guess, very good prognosis or low risk, medium, and high risk when you combine HPV positivity or negativity together with your smoking history. And if you use a cut point of 10 pack years, the best group, that low-risk group, is going to be where you're HPV positive and you are essentially a non or very light smoker. And there you can see the 5-year survival is somewhere in the order of 80 or 90%, which clearly, I think, has implications in terms of increasing efficacy. That's going to be difficult, but perhaps reducing toxicity. So I must say, although I don't think there's data for that just yet, although the trials are ongoing, when I look at the patients in clinic in terms of chemotherapy, I am swayed by their HPV status as well as their smoking status, looking at this sort of prognostic grouping. So I put up this slide here just to lead into what the concept that I think head and neck cancer is an extremely complicated cancer. And whilst we always pay, I think, sometimes lip service to the fact that we need multidisciplinary treatment, I think that is absolutely true in head and neck cancer. And I'm not sure how many of you are familiar with the NCCN guidelines. I assume most of you are. This is actually the simplified version. I had to cut and paste a few things. There's pages and pages of this. But I chose this just in terms of looking at their guidelines for glottic larynx because it allows me to perhaps make some brief comments about the treatment of early versus late disease. And the first thing I want to say is that, I think as I come back to multidisciplinary care, all of the medical and surgical specialties working together is essential. On the left-hand side alone, you can see the very complex patient workup that's needed for most patients with locally advanced disease. Imaging is absolutely vital, but also surgical assessment, endoscopy. The patients need to have a lot of assessment of their comorbidities with that. So when we see the patients in clinic, they're actually quite confused. We're often the last group of the doctors that they see, and they've just met so many people in such a short period of time. They are very, very confused. And so, in fact, we find that having a support person is very important in that. Just for the purposes of this meeting, I just wanted to highlight that, in the NCCN guidelines, it said considered PET for CT PET for locally advanced disease. Certainly at our site, we have very strong PET facilities. We do it essentially for all patients. It's standard for us. I can't remember a patient last time, well, unless that very early, who didn't have a PET already done by the time they came to the multidisciplinary meeting. And so there's lots of this data around. I chose the local data here for obvious reasons, but this was a retrospective review that was done at our center looking at the impact that having PET scanning at baseline in your patient assessment and treatment planning, what impact that had. It was 71 patients at our center, and you can see on the left that the details are not important, but if you look at the planning before PET and the planning after PET, the key things that jump out is that about nearly 40% of patients are usually upstage as a result of having the PET scan. And this is usually associated with some sort of treatment change, usually more aggressive treatment, if you look at the fine print, but occasionally sort of treatment de-escalation, which is rarer. And that works day to day for me in our MDMs. That really does work. We're very, when we look at the patients, aside from the structural imaging, myself and my colleague, my radiation oncologist, want to know about the PET and the HPV status as well. And this is to show that I think that that the PET staging, I think, does have trend towards better prognostication, but I think it's really for the treatment planning that we use it more for. So I guess in terms of the treatment paradigm, certainly at our center, we feel that where possible, perhaps with the exception of where there are functional implications, where possible, primary remains the first treatment modality of choice. And I come back again to this NCCN just to illustrate that if you have, obviously, anywhere up to an unresectable tumor, there is a role for surgery to be had for those patients up front. And my surgical colleagues do often debate quite extensively the various approaches that they use, which I'm never quite that familiar with, but it's something that's obviously key. But I think that it's rare, unless you're very early, multimodality treatment is what most patients need to have the best outcome. So after surgery, based on their initial staging, particularly their T stage, if it's T3, T4, or what we discover subsequently afterwards in terms of risk factors. So for radiotherapy, obviously risk factors like lymphovascular invasion and perineural invasion and depth of invasion, as well as positive margin extracapsular extension. I mean, those are what guides the radiotherapists. And then for us, we've been very much guided by the data that have come up from 2 seminal trials as to when we offer concurrent chemoradiation. So I think that for us, it's very clear that if you have positive margins, which we often keen to clarify at the end that this is within 5 millimeters on one rail margin, so to speak, and that if there's extracapsular extension, that we can see that adding some concurrent platinum-based chemotherapy results in significantly better outcomes. So it was both for of survival as well as your disease control there. This is the European study. I just picked that just for illustrative purposes, and it illustrates the points I wanted to make, that you see improvements in patient survival, and you also see a reduction in terms of local regional failure. So that's I think, pretty standard. So I think that that's for adjuvant treatment that's there. So what about for the patients who we decide not to have surgery upfront for whatever reason? And I think this often particularly is the oropharyngeal patients where surgery would be functionally and very debilitating, and we think that we can have equally good outcomes. So that's where a lot of where I come into is where we're going to give chemoradiation for locally advanced disease there. So I think that this is just a very brief key points about in terms of the adding chemotherapy to radiotherapy. The meta-analysis showed that if you have platinum chemotherapy, overall that was a 6.5% absolute survival benefit to be had with concurrent platinum therapy. And for me, it's about really deciding who is up for platinum chemotherapy. And so it's with platinums, I mean, these are drugs that have been along for a while. The problems with emesis, I think, are in the past with much better antiemetics. But, you still do have to be cognizant that a patient with significant problems may not tolerate that. Something that may be peculiar to Australia, of course, is that we'll come to the ability of cetuximab, the anti-EGFR antibody, is restricted and only for platinum incentives. So I must say we routinely check for hearing impairment as one of the platinum toxicities that modulate my treatment planning, and we'll come to that in a moment. But just again, this is going to whiz through the the data behind what we do. So I think that the current standard of care chemotherapy regimen with what I call high dose or chemotherapy cisplatin is based on the intergroup study, which is quite an old study. And it actually had 3 arms, but I'll be focused. The third arm was a very complicated arm, which I'm not really going to talk about anymore. But the arms A and B were really essentially a relatively straightforward comparison between radiotherapy and radiotherapy plus cisplatin. And the cisplatin was given 100 per meter squared, days 1, 22, and 43. So start, middle, and finish of radiotherapy, as I say to the patients. And you can see that, that the main difference was between the radiotherapy arm and versus the radiotherapy plus chemotherapy. And the study actually did not reach its full accrual, but despite that showed a positive difference for the chemoradiotherapy versus radiotherapy alone group. And the 3-year survival was 37 versus 23. We're going to come back to some of these figures, but just maybe keep that 37% in mind for chemoradiotherapy using an older study, really. But without doubt, there is a price to be paid for this increased efficacy. And we can see that there is more toxicity with chemoradiotherapy. There are when I talk to patients, I say, look, you're going to get your toxicities from radiotherapy. You're going to get all, potentially the skin, the mucositis changes, the feeding issues, that the chemotherapy might make that a little bit worse. But that there are specific chemotherapy side effects that we talk about as well. But they're actually relatively rare. I would say that what I find is that hearing impairment is probably the most common. I've never had anyone go deaf. In fact, most of my patients never even use the handful that might benefit from hearing aids never even use it. It's been a long time since we've had renal impairment on neurotoxicity. And MS is also relatively well known. So I don't know, maybe I'm biased, but I actually find cisplatin to be not difficult to give. And some interesting colleagues say that, in fact, weather, Australia has a broad weather differences in weather, that further north it can be very difficult to give, actually. And our radiation oncologists actually prefer the cisplatin rather than cetuximab as a choice of treatment. So coming to cetuximab, so I think that this was a study that was done asking the question whether can we use something else other than cisplatin, for better tolerability. And so this was essentially a study now randomizing patients, now, importantly to radiotherapy alone. That was the control arm, not chemoradiotherapy. So radiotherapy alone together with radiotherapy plus cetuximab. And in brief, cetuximab is a anti-EGFR antibody that is commonly used, and there is certainly a feeling it's well tolerated. And so this was just a randomized study looking at radiotherapy versus radiotherapy plus cetuximab. Now, the scheduling of cetuximab is different. The chemotherapy is given 3 weekly, but cetuximab is given weekly. You have to give a loading dose, and then you have weekly infusions during treatment. And sometimes from a scheduling point of view, it's a bit of a problem if the radiotherapy is meant to start, and it's been a sort of more complicated planning, then that extra week can sometimes cause just a bit of logistical problems. But we've almost always made it work. And here you can see that the combination group certainly does do better. You can, at the 3-year, you go to the combination group was 47% versus 34%. Now, I think we can see now this study there's never been yet a reported study of radiotherapy with cetuximab versus radiotherapy plus cisplatin. And it is not safe to just compare across studies. It should never be done anyway. But for example, I think that when we look at the reasons why here, I don't know if you remember, but in the original intergroup study, the chemoradiotherapy group had a survival of 37%. Whereas here, the control group, the radiotherapy-only group, has a survival of 34%. And I think this is clearly better patient selection and staging, etc. So I think that the jury is definitely, I don't believe that at this time you can say one is better than the other because there is no data to support that, although that may change. Or this is just survival, again, showing that there's also a benefit of overall survival. So, that's where we are in terms of concurrent chemoradiotherapy. We have to use cisplatin in terms of access to drug. We have to use cisplatin unless we can find a reason not to, which can be defined a priori by the medical oncologist, and then cetuximab is another option. Certainly in Australia, I think there's some debate that rages about the weekly cisplatin versus the weekly platinums, and people have very firm and deeply held opinions about this. I am of the camp that the 3 weekly is the way to go, but happy to discuss later if anyone wants to. And then I think the last thing I want to talk about is pertinent, particularly this meeting, is obviously the role of PET scanning after non-surgical treatment. And certainly at our center as well, we feel that functional imaging with a PET scan is our standard and strongly guides treatment. It's consistent with the NCCN guidelines here as well. And essentially, after chemoradiotherapy, after a 3-month period to allow the swelling and inflammation to go down, we would restage with sometimes just a PET, or PET and structural imaging. And essentially, if there has been significant radiological regression and there also a metabolic response, we are happy to continue to observe. Even very mild residual uptake, if our nuclear medicine colleagues tell us that they are not worried, we will not proceed to the completion neck dissection, which used to be very common. I think that again, I'm going to show, so just showing some, I think the Australian data I was going to comment from Peter McCallum suggests that the negative predictive value is 100%. I think most of the studies show much the same thing. I do want to pause for a moment and just talk about, there is the efficacy side of the equation and the patients that we can cure with our treatments, with multimodality treatment. But it comes still at a very, very high price for our patients. And I think that here I've just put a list of, just illustrations of the common toxicities that patients have to endure. Some transiently, as they go through radiotherapy and chemotherapy, but some permanently. And certainly you can see someone who's had a laryngectomy there. That's going to be a permanent issue they're going to live with. And when I talk to my patients, I say to them that the 3 side effects you're going to be left with, and I use the phrase medium or long term, is you're going to have a very, very dry mouth. Unfortunately, that's going to be associated with very thick, annoying saliva. And your food taste is going to change if you're lucky, or you're going to have food that's going to taste terrible if you're not. And I always tell them this at the start, and they're still often very surprised at the end, because it's such a difficult treatment to go through, and people tell you so much stuff as you go through treatment. So I think toxicity, and I often think if it was me going through this, knowing what I know about toxicity, I would hesitate. And lastly, come back to this, I think that we're talking about non-surgical approaches. I just want to make 2 key points, probably. One is that, in my opinion, that there's no proven role for induction chemotherapy at this time, in the sense that there is no survival benefit. There have been lots of studies, the decision, the paradigm, meta-analysis. This is the Spanish study, which in fact is the only one that I think compares induction together before chemoradiation to standard chemoradiation. For those who follow the literature, this is a controversial study, but it is consistent with the rest of the literature in showing no survival benefit for the induction chemotherapy. But sometimes survival, as I said, is not the only criteria that it's not the only aim of our treatments. There's also preservation of function, and I think that's where organ sparing or laryngeal preservation, I think there is a role in that. I'm just going to touch on that briefly. So this is the original veteran study showing that you could, in fact, for patients who have laryngeal cancer, you could, in fact, safely substitute chemotherapy and older regimen of platinum and fluorouracil. And as a result of that, you could actually preserve the larynx in about 2/3 of cases. And that this did not come at any detriment. That was perhaps, that the toxicity was management and survival was what in this study was unchanged. But this is one of the seminal papers. I think the next one is the TOG 9111 study. So this said that the initial VA study said that chemo with then radiotherapy is the same as surgery, then radiotherapy, sequential treatment. And this study then asks us the question, what if we compare that with combination treatment, which has been shown in other cases to be superior. And you could probably, this is a busy slide, but just to take you through that, I think if you look at the top left, so this study compared radiotherapy versus chemotherapy, then radiotherapy, or concurrent. And I think the concurrent is probably coming out ahead. You can see that for laryngeal preservation at the top, I think it's a red line there, that the laryngeal preservation is superior with the concurrent chemoradiotherapy and with laryngeal free survival. But the late results of this were interesting, and there was raised some concerns, and it probably doesn't come out that well, but if you look at panel C, there did seem to be perhaps an increase in non-cancer-related deaths at the time. So that's certainly something that is been discussed as well. But I think that, so I must say for myself, given that that this is non-significant and that there's superior local control and larynx pressure, where I would tend to go with the chemoradiotherapy. But sometimes where there's large tumors or we need to start rapidly, go with the induction approach first. There's also the fact that can sometimes tell you about subsequent, for chemo selection, radio selection, but I do find that it's generally, I find that it's very responsive to chemotherapy alone up front. So just to wrap it up, so that was really, I think, just a very quick high-level flyover about head and neck cancer and its treatment. But where are we going from this? And I think that, and specifically, where is it that maybe nuclear medicine can add in the future? How can it help us with some of our challenges and opportunities? And I've divided this into the HPV positive versus HPV negative, and these are my thoughts on that. Happy to discuss, of course. I think that for HPV positive, it's probably more about reducing toxicity. I think they're very good outcomes, but that is with fairly toxic treatment with high-dose cisplatin. I do not currently believe that substituting less toxic treatments is proven yet, although there are studies underway for that. Depending on your initial prognosis, I'm not sure that it's going to take a lot of very large studies to improve survival in sort of relatively unselected population. And whereas with HPV negative, I think that we could still certainly want to do better. I think efficacy is still our most important endpoint, but reducing toxicity is also clearly vital. And what we don't really have, aside from, as we talked about, perhaps HPV and smoking, is I don't think that for head and neck cancer yet has moved into the 21st century in terms of molecular characterization and selection that I think would be where ideally we would go. And I think that some of the other speakers will probably start to bring up the roles that the role that nuclear medicine could potentially play. And I just want to take the last few slides to talk about some of our own interests and what's going on here. So I think that EGFR therapy clearly is important for both the initial treatment as well as for curable disease. I didn't really touch upon it, but EGFR therapy in the first-line recurrent setting with chemotherapy clearly is also better than chemotherapy alone. But I know that a lot of time was actually spent to try and find the biomarkers of increased efficacy, and they do not exist at this time. But as an example where I think that perhaps imaging can help, so our group here, our lab here, is very, we have a lab program where our focus is on tumor-specific antibodies. So we have our particular antibody is an anti-EGFR tumor-specific antibody, whereas cetuximab, for example, and most other EGFR antibodies are non-specific. They bind to skin and liver, which is why you get all the toxicities. And while I don't have time to go into it, it's published literature that with this antibody, by targeting the different part of EGFR, you can get tumor-specific targeting. So all that shows here is that, as you see, that the delta 27 is an EGFR mutated and constitutively activated cancer, and you can see that we can detect that in the cancer very specifically, and there's no evidence of binding to organs with normal EGFR. We also have human data for that now, which I show, and you can treat to sort of ridiculously high doses of ABT806, 24 mg per kilo, and you see no normal tissue binding, no toxicities, not a pimple, not a rash. And you can also, and again, here we show on this occasion targeting to GBMs, which I'm giving a talk later today. But here is some data we presented earlier, and the key point I wanted to make was that using this tumor-specific anti-GFR antibody, we labeled it with indium, and then we imaged it. And what, I might just skip this for the purpose of time, just to say this is the mechanism of why we can achieve tumor specificity. But when we did the study of the naked antibody, we also, when we did the study of the naked antibody, we also did imaging of patients when they started. And on this study, we had one patient who had head and neck cancer, who had a partial response that was maintained. He was the only objective responder. And of course, he had very, very high uptake at baseline. So potentially, here's using a tumor-specific labeled antibody with functional imaging, we can perhaps, it suggests that perhaps it's a possibility of patient selection. So that's my own data. I'm probably a little bit biased by that. So I think that really there is a great opportunity for us to improve outcomes, and I personally feel that functional imaging has a role to play in this, but much work remains to be before that can happen. Thank you very much.
Many thanks, Hugh, for the clinician's perspective and for making a very complex subject simple for us.
Thank you.
Thanks very much.
Thank you. Thank you.
Now we can move forward to the next speaker. It's an honor for me to present Professor Rathan Subramanian from the US regarding the aspects SPECT-CT lymphoscintigraphy and PET-CT in head and neck cancer.
Good morning. It's truly a pleasure to come to Melbourne. I call it my hometown. I trained here in University of Melbourne, and now I'm in the south of United States. So over the next 30 minutes, what I'm going to do is to give an approach to head and neck PET-CT reading and some of the pitfalls and the mistakes I and my colleagues made so that we will be all aware of it. The lecture is divided into 4 parts. Introduction, which I will touch on the previous talk. Again, HPV-related disease. Then I'm going to discuss the illustrative cases and how we would approach, and finally, the pitfalls. The primary question we are trying to answer for our clinicians is this. Is the treatment for this patient is going to be surgery or chemoradiation or a combination? That's our job. Head and neck cancer is the 6th common cancer in the United States, and we spend almost $4 billion taking care of these patients. This was touched on in the previous talk. If you looked at the incidence and mortality for lip, oral cavity, and laryngeal cancers, the incidence have been declining simply due to the decline in smoking and alcohol use, so that the mortality is declining. For the tongue and oropharynx, the incidence is increasing due to HPV-16 disease, and the mortality has plateaued. So, as illustrated previously, you can summarize the risk factors: alcohol, smoking, and HPV-16 disease. And the HPV-16 disease, it's truly an epidemic, and I'll go through that in a while. The head and neck cancer management can be summarized by this simple diagram. If this disease is local or early stage, it's a monomodality therapy either you treat with surgery or radiation therapy. If it is advanced, it's a combination therapy. If it is metastatic, it is palliative chemotherapy. And we can add one more point to this. If it is recurrent head and neck cancer, now we can utilize immunotherapy. That simple paradigm sustains all over the head and neck cancers. So what the clinicians want to know from us? There are 4 things they would like to know from us, from our PET-CT reports, or even CT neck report or MRI neck report. The extent of the primary. Does the primary crosses the midline? What does the primary do for the adjacent structures and the local and distant metastases? This is the view surgeons see when they put the laryngoscope. They can see the entire mucosal surface. 90% of the head and neck cancer is going to rise from this mucosa. And by the time they send the patients to us, they know there's a cancer. And they can see even smaller cancers than we can see with any of our imaging modalities. What our job is to articulate is the third part, that is the submucosal spread of the disease and its effect on the local regional environment and distant places. So if you take that paradigm, what the clinicians want to know is a series of questions answered in our reports. Does this tumor crosses the midline? Does this tongue tumor invades the floor of the mouth, base of the tongue, or the glossotonsillar sulcus? Does it invades the mandibular rim, or it's metastasizing to the upper level lymph nodes? That simple strategy will govern all the cases I'm going to discuss. I want to touch on briefly on HPV-related disease before I move on to the cases. This is a beautiful example of a HPV-positive head and neck cancer, and you can explain really nicely by this diagram. These tumors tends to be small, the primary tumors, and the metastasis tends to be much larger. That's the general phenomena. And it is not universally common to all sites of head and neck cancer is affected by HPV disease. If you carefully look at it, vast majority of the head and neck cancers come from the oropharynx, 80%. 80% of the head and neck, HPV-positive head and neck cancer is from oropharynx. About 30% of the sinonasal tumors are HPV-positive. And the remainder of the sites, it's about 1 to 2%. So the HPV-related disease is a disease of oropharynx predominantly, and to a lesser extent, the sinonasal cancers. This slide summarizes younger median age. They are in their 18s, 20s, 30s, and 40s. Small primary tumors, high neck nodal involvement. Usually, they are not keratinized. Let me explain what that means. And usually do not have typical risk factors. They have improved performance, and more than 80% are cured. That's why reducing the morbidity is important for them, not advancing the efficacy. But I want to show you some images how this disease manifests. They come up with unusual distant metastases. It's very rare to see mediastinal nodal involvement in an HPV-negative head and neck cancer. However, you would see occasionally with HPV-positive head and neck cancer, even the mediastinal disease, as well as organ metastases. That is very unusual for HPV negative, but occasional for HPV positive disease. Here's a case that was treated, disease-free, and after 2 years came up with widespread bone skeletal distant metastasis, and that is the disseminated, delayed manifestation of HPV disease. Why is this different, this disease? Here's the explanation. I'll take you through slowly. HPV 16 colonizes in the tonsil. Most of us went to medical school, and we know when a tumor invades through the basement membrane, it's called invasive or aggressive cancer. Not so with HPV disease. That's the distinct difference between HPV disease and other cancers. Because the tonsillar crypts the basement membrane has pores, hence those viral deposits take place underneath the basement membrane. Hence, the tumor is already developing underneath the basement membrane without the invasion of the basement membrane. That's why this is a really good cancer, but appears under histological slides as an aggressive pathology. That's the basaloid features. They are well-differentiated cancer despite its histological features of poor differentiation. Not all the HPV positive disease are good. There's a variant called small cell variant that does not have the advantage that we talk about of survival. They are rapidly progressive, they have poor survival, and usually they are associated with smoking. All right, with that, I want to move to the cases. I'm going to discuss the cases in 5 head and neck regions: oral cavity, oropharynx, larynx, and hypopharynx. I'm going to leave out the nasopharynx because that's a distinct, different entity. And as many of us know, there's a nomenclature of description for head and neck cancers, the lymph nodal levels, and I will go through them as I go through the cases. I would do the first 6 levels. I would not discuss the 7th level, that's upper mediastinal nodes. Case number 1, for all of you to think about. So, these are 2 different cases. They are corollary cases. My question to you is, where is the tumor and how it's going to spread? Where is the tumor and how this tumor will spread? There are 5 distinct sites tumors arise in oral cavity. And this site is the most dangerous space in oral cavity cancers. This is a retromolar trigone tumor. The picture on the left side, the picture on the left side shows that's a mandibular retromolar trigone tumor, and that's a maxillary retromolar trigone tumor. This is the dangerous space in head and neck and one of the sites. And it's a unique pattern. It can invade the buccinator muscle or superior laryngeal constrictors, or it can invade the mandible, or it can get into the oral tongue very easily, and it can spread up and down by the mandibular raphe. So the pterygomandibular raphe is a fascial thickening that sits in this spot between the buccinator muscle and the constrictor muscles. and it provides a conduit for this tumor to spread up and down into different spaces. That's why this is a dangerous space and a dangerous tumor in head and neck. I'm going to show you the other 4 locations of head and neck oral cavity tumors. It's the anterior tongue. The questions are the same. Does it crosses the midline? Does it invades the bone? Does it invades the neurovascular bundle? And where is the local regional and distant metastasis? This is a lateral tongue tumor. Again, the questions are the same. This is a floor of the mouth tumor, and most of the time you can see how it would spread very nicely. It can invades the mandible or crosses the midline or deeply into the deep musculature of the oral cavity, or it can invade posteriorly. In this region, it has significantly affected the floor of the mouth as well as the mandible. The buccal surface tumor, it's on the inside of the cheek, and if it is large enough, you don't need to do any maneuvers. You would see the intense FTG uptake. And the questions are very simple again. Is it involves the buccinator muscle? Does it involve the mandible, or is posteriorly extending into the posterior structures of the oral cavity? Those are the very simple questions we need to ask in our reports. One of the techniques we can do with PET-CT as well as CT, if the tumor is small, you can ask the patients to puff the cheek and hold it for one bed position, and you can do beautiful PET-CT images to show the buccinator tumors. I want to discuss the nodal levels for these oral cavity tumors. They usually go to level 1, 2A, 2B, and sometimes to 3. The level 1 is the nodes just below the mandible, and it can be divided into 1A is the submental nodes. You can cheek underneath your cheek, and or the submandibular nodes that's further down on the side of your mouth. If you feel, you can feel it if you have a node there. And in PET-CT, you can really nicely see with this large tongue tumor with a level 1B on the right side, as well as level 2A lymph node on the right side. So that's the descriptive language you want to describe for the nodal levels. Or the level 1 is anterior to the posterior margin of the submandibular gland. And the level 1A node is just underneath your chin, in between the anterior belly of the digastric. Level 2 is the commonest site for all the head and neck cancers. If you are reporting a PET-CT and if you are saying there's no nodal metastasis, please look carefully. This is the site you want to look for. And it's usually from the posterior margin of the submandibular gland to the posterior margin of the sternocleidomastoid muscle. And level 2A is anterior to the vessels, 2B is posterior to the vessels. There's a descriptive language that we use. You can see on this slide, you have a meted nodes. This is still called the level 2A. Here I can show you the two distinct level 2A as well as level 2B nodes. The way you separate those is by CT. You have to realize and recognize there is a fat plane between the nodes in 2B and the vessels. So without that fat plane, it's still called 2A. And this is due to the surgical approach the surgeons have to make when they dissect the necks. Case 2, I'm going to touch oropharynx. Again, where is a tumor location? It's a palatine tonsils tumor. The tumor and how it would spread. The palatine tonsil tumors have multiple ways to spread, and I'm going to slowly show you in which direction this will go. On the axial images, you can see it can invade the buccinator muscles. Laterally, it can invade the mandible. Posteriorly into the vessels, and also into the pharynx. On the sagittal image, you can see it can easily invade into the soft palate. I have seen many cases invading into the soft palate and encroaching into the hard palate. So when you are looking at a palatine tonsils cancer, that's what you're looking for. Again, extension to the soft palate, posterior laryngeal wall, anterior to the glossotonsillar pillar, and posterior inferiorly to the hypopharynx. Here's an example of a basal tongue-based tumor. They are usually bilateral nodal metastases. With small tongue-based tumor, you can see large nodal metastases bilaterally. Here's another palatine tonsil tumor. It is isolated to the tonsillar pillar on the right side. However, this nodal metastasis bilaterally in the upper level next. Case 3. We're going to look at the larynx. Larynx is divided into 3 parts: supraglottic larynx, glottic larynx, and subglottic larynx. It's divided by this, and probably nicely shown by this coronal pathological slide. And in CT, the way we recognize is the supraglottic larynx would have fat, the glottic larynx would only have muscle, and the subglottic larynx only will have mucosa. That's how we would recognize it. So where's this tumor? How would it spread? And just looking at that axial image, you can see this is a supraglottic laryngeal tumor. Why? You can see the fat. If you don't see the fat, it's going to be, if you see the muscle, it's going to be the glottic tumor. And if you only see the mucosa, it's going to be the subglottic tumor. Here's an example of those. That's the supraglottic tumor. This is the glottic tumor. And this is, again, a glottic tumor. And you can see, you only see the glottis or the vocal cord, the muscles, and you don't see a fat next to the muscle. And the subglottic tumors will have just mucosa. And the tumor spread, again, we look at the same 4 phenomena. Does this crosses the midline? Is it extending through anteriorly through the thyroid cartilage or laterally through the thyroid cartilage, or it's extending posteriorly into involve the cricoid cartilage? And the key pieces are, does it crosses midline? What's the adjacent structure it's invading to? And what's the nodal metastasis it has? That's a simple phenomenon that we do again and again in head and neck. Level 3 lymph nodes. They're at the level of the laryngeal cartilage. The way you recognize level 3 node is to recognize the thyroid cartilage. Case 4, I'm going to discuss the hypopharyngeal space. So where's the tumor? How would this spread? Based on these images, you can see the tumor is involving the left piriform sinus, and the right piriform sinus is very nicely shown. And the piriform sinus tumors have this propensity. They can be very small, but they're nodal metastasis, and also they can have distant metastasis. In this case, let's say level 3 node, and if you look at this piriform sinus tumor, it's a fairly large tumor, already have a distant metastasis in lung. And that is typical of an HPV negative disease going to lung. And they have bad prognosis compared to other sites in head and neck. Level 4 lymph nodes, they are posterior to the border of the sternocleidoid muscles and inferior border of the cricoid to thoracic inlet. That's where you find the level 4 lymph nodes. And level 4 is, as I said, delineated by this red line, because when we call supraclavicular nodes, we are mixing both level 4 and level 5, because anything medial to that red line is level 4, anything lateral to that red line is level 5 lymph nodes. And the best way to recognize level 5 is sagittal view, because if you go through the sagittal view, you would really nicely see on the PET scans, very nicely, it's bordered beyond the posterior margin of the sternocleidoid mastoid muscle. The level 6, usually the thyroid cancer gets there, and it's medial, it's midline, it's medial to that 2 red lines, so it's medial to the vessels in the neck. To put it simply, is it under the chin, then it's level 1. Is it posterior to the sternocleidoid muscle? It's level 5. Is it beside the larynx or thyroid cartilage? Then it's level 3. Is it above the hyoid bone? Then it's level 2. I think this is the best way if you are struggling to characterize, but you would do a great service to your surgeons and the radiation oncologist if you describe it this way. Couple of other notes I haven't touched, but I want to emphasize retropharyngeal node. It's important because if you identify a lateral retropharyngeal node, then it shifts the treatment from surgical to a non-surgical treatment, simply because it's almost impossible to resect this out. So normally it's treated by radiation therapy. I also want to, for the nuclear medicine physicians, the lymphoscintigraphic patterns and the nodal metastasis, you look at if this cancer is in the parietal region or in the occipital region. It usually first goes, if it's the parietal region, it goes to the posterior auricular node first and level 2A second. If this is in the occipital region, it goes to the occipital nodes and then to the level 5 nodes. Here's a nice example of that. You have a parietal region node, and it goes to the posterior auricular and occipital. And you have an occipital, you have an occipital lesion that goes all the way from the occipital node to level 5 nodes. That's the pattern of spread that you would see with tumors, skin tumors in the scalp. On the other hand, if you look at tumors in the oral cavity, they follow the typical pattern that I just described, the upper echelon nodes. And this lymphoscintigraphy really nicely demonstrates how it spreads to, that's the tumor injections at the primary tumor. Here's the level 1 node. Here's a group of level 2A nodes. And here's the level 3 node. And you can see there's a direct channel as well as a bypass channel, how the tumor spreads. And the lymphoscintigraphy really nicely shows that pattern that we would miss in the SPECT-CT simply because SPECT-CTs are static images. They would show where the drainage patterns, but it doesn't really show this really nice dynamic pattern. Can someone forward my image? It's not working. Okay, I think the last couple of minutes, I really want to go through some of the mistakes I made and the pitfalls. This is a case I saw in Boston University when as my first faculty position. And this patient had a head and neck cancer, treated, disease-free, came back with a cheek. And if you carefully looked at the scan, you have the recurrent side, but when you further down look at carefully, it's just extending through, and it's probably about to enter the infraorbital foramen. And that is a pattern that you would see again and again carefully if you look at the PET-CT images, because it's a perineural spread. PET-CT is not sensitive like MI is. MI is more sensitive. However, PET-CT is very specific. So look for this perineural spread when you have head and neck cancers. Usually it's typically more common along the V3 nerve. This is the second case, again, from Boston University. It was early in my faculty career, and the surgeon asked me, rather than, can you tell me this tumor is invading the mandible? I have repeatedly said that's one of the questions the surgeons wants to know. Here's the tumor. That's the retromolar trigone tumor that we discussed. The dangerous space. That's a very small tumor. And his questions was, is it involving this mandible? Because that would change how he would approach in the OR. I looked at it, and I said, no way, this is, the cortex is not breached, so it's not involving. What it was turned out to be, when he went in, he just tested, and it was filtered with tumor. So what it tells is PET-CT underestimates the marrow involvement. I think MI is much more sensitive. MI is not specific, but PET-CT underestimate marrow involvement, so you have to be careful. This is a nice case. This patient has lymphoma, is already known, came for initial staging, and I looked at this head and neck nodes, and I said, it's very unlikely to be involved, most likely reactive. Patient had one cycle of a combination therapy, and we came back because this was on a trial. This was really got better, and all of a sudden, all these nodes that I thought reactive is just lighting up, and there are nodes on the other side. Patient is on therapy, and this is significantly improved. And I didn't know what it was. I thought I made a mistake. So I told the surgeons to biopsy this, and they biopsied, came back granulomatous disease. And eventually, we didn't believe the biopsy. It was surgically dissected out, and still is a non-caseating granulomatous disease. What it is, the patient was HIV positive. Hence, you have to be really careful with HIV positive patients. This was a case again from Boston. My chief asked me, this patient had a head and neck cancer on the left side. You can see it, treated, disease-free for 9 months, and this was about a year after the initial onset of the disease. And my chief said, looked at me and said, what do you think? And I said, this must be recurrence. Look at this, all of this lighting up like, what it turns out to be, all of this is really a patient was applying hot pack, so thermal-induced therapy. That's what this was. Since our time, I'm going to wrap up quickly. This was a muscular graft uptake. This is not recurrence. You want to be really careful. The best way to look at this is on the sagittal images, and I have seen many physicians make this mistake when I asked to second read these cases. This is a typical pattern for in young patients. You would see intense parotid gland uptake, and it's very clearly different from the different types of tumors, parotid tumors that you would see. This is this pitfall I want to say, because you may see this again. This patient had a laryngeal tumor. You can see it very nicely. Surgeon asked, and what this was is they put the laryngoscope and suspended on the glossotonsillar ligament. They ruptured the ligament. This is just a rupture of the ligament. It's not a second tumor. Finally, this is my last slide. It's when would you do PET-CT? I only want to stress 1 point or 2 points. 12 weeks after the conventional chemoradiation, and if you did immunotherapy, please do it at least 4 months after the treatment commencing. With that, I want to summarize the value of head and neck PET-CT, and I thank you for all of your time, and thanks for kindly inviting me to give this talk.
Thank you for this great overview. Excuse me, Professor. On behalf of the organizing committee, thank you very much.
Now it's my pleasure to introduce Professor Michael McKay, who's a radiation oncologist at the Austin here in Melbourne, and he's going to talk about PET and radiotherapy planning and response monitoring. Thanks, Michael.
Thank you very much, and thank you for the organisers too for the invitation to speak today. So today I'll be talking about molecular imaging mainly using FDG PET where not otherwise mentioned, for radiotherapy planning in head and neck cancer. So in the talk today, I'd like to cover some of the concepts in modern radiotherapy and radiotherapy planning for head and neck cancer, some of the potential roles for PET in assisting the radiation therapy planning process, and also some of the practicalities in the implementation of good quality chemoradiotherapy in conjunction with molecular imaging. And then briefly to highlight some of the drawbacks of PET in this setting. So, don't seem to be progressing there. So, as we've heard from the other speakers, there are the main modalities used to treat head and neck cancer, also increasingly using biological therapies and immunotherapies. So we've come a long way with radiotherapy in the last 100 or so years. This is an image from St Vincent's Hospital here in Melbourne showing an early radiotherapy clinic. So in this case, the head and neck cancers are actually skin cancers, and the nurses are handing out radium vials to various patients there and telling patient A, B, C, hold that radium vial against that cancer for so many seconds. And so that was how radiotherapy was done here 100 or so years ago. These days, we like to think of tumour cure as the main focus of our therapy. But of course, for all therapeutic agents, we need to balance that against the side effects of therapies. And for radiotherapy, we can consider a more sophisticated version of this small image here, including these sigmoid dose response curves for cancer cure and for significant complications or side effects. So as you'll notice, the curves have a very steep dose response. This indicates the chance of one of these events occurring. And down here we have the treatment dose intensity. Just having a bit of trouble advancing this slide with this thing. So here we have an example of, for example, if we gave a certain type of dose intensity, this of the lower level here, and looked to see what effect it had on these two different parameters. So there'd be a relatively low risk of significant complications, but also a fairly modest amount of tumour cure. If we decided to dose intensify perhaps 20% or so, and so this isn't a massive amount, it's not double the dose or anything like that because of these steep dose response curves, small dose intensification, what would the effect be? Well, this could have a great effect on tumour cure, but the problem is an enhanced significant complication rate. As shown there. What we'd like to do would be to move the complication curve to the right. And there's various ways that have been conceived to do that. And one of them might be to decrease the size of the radiotherapy target in head and neck cancer. So if the target was smaller, we may get less complications. And by doing that, you could envisage then by using the higher dose, still the lower level of complications, but you might increase tumour cures significantly. So as we've heard all through the conference, there's very many ways that PET contributes to oncology. These include diagnosis, staging. Radiotherapy treatment planning is a relatively small component of PET's contribution to oncology, but that's what we're addressing here today, as well as response evaluation, etc. So what happens during radiotherapy planning? Initially, we get a patient who is evaluated in the clinic or in the multidisciplinary team meeting, and a decision is made to treat. Patient then goes to a radiotherapy planning simulator, where they're usually simulated with a plain CT scan in the treatment position. And for head and neck cancer, that simulation involves thermoplastic shells, which will include the shoulders as well for immobilisation. You can see the lasers here that are also used to line the patient up in the simulation area, as well as they'll be the same lasers used in the radiotherapy treatment room. And we'll come back to that positioning importance later on in the talk. So for radiotherapy, we need a target. And the main part of the target is the gross tumour volume. So this slide here shows a different anatomical location, but the principles for the target voluming are the same. So the gross tumour volume is shown in red, and that's determined by various imaging modalities. Then the gross tumour volume is expanded to allow for other factors such as subclinical extension of tumour, which could be covered in the clinical target volume. And then other factors are covered, such as patient movement during treatment, or organ movement, or day-to-day setup variations covered in the PTV. But for most of the talk, I'll refer to the gross tumour volume, or the GTV. So what actually happens in creation of the radiotherapy plan? So firstly, the normal tissues in the treatment areas are delineated by hand usually, although they're developing algorithms now to help in the automation of that process. But it's usually very time-intensive delineation of normal tissues and tumours on maybe 3 millimetre slices of all CT sections through the head and neck region. Then that's additional imaging is incorporated or fused with a planning CT scan, such as the MRI or PET scan. And the team creates a 3D treatment plan. And the treatment plan conforms highly to the target shape, and it also maximises sparing of adjacent normal body structures. So there are various tools that are used to evaluate these normal tissue and tumour target contours. The doses to normal structures are limited to established safety guidelines. And then finally, there's a customised or individualised treatment plan created. and that's with multiple unique beam angles, and each beam has a three-dimensional shape due to beam intensity modulation. So intensity modulation has to do with IMRT, which we'll mention now. That creates a treatment plan. So the treatment plan has isodose lines like barometric lines that you see on the weather report that show the actual doses that are the same in the different areas. So in this particular example here, the maximum dose is in green there to that's that particular area. These other areas here, these would be intermediate doses here and lower doses to prophylactic areas that are at lower risk that would get lower radiotherapy doses at the periphery. So that entire treatment process and the plan has to be signed off by the radiation oncologist. After the plan is made, it's implemented, and this is simply to say that there's quite a detailed image-guided radiotherapy process where prior to every treatment there are cone beam CTs that are done to ensure that the patient and the tumour are in the exact location that's required prior to the treatment, and that's done in real time so that the treatment could be adjusted if there was any if the images were not within the standard parameters. Patient then undergoes radiotherapy on a linear accelerator, and on this accelerator here you can just see a small cone beam CT that's used for treatment verification purposes. IMRT, that's the name for a modern radiotherapy essentially for head and neck cancer. It's modern radiotherapy, IMRT. It stands for intensity modulated radiotherapy. So usually for conventional radiotherapy beams, the beam is actually flat. In IMRT, there are mountains and valleys in each beam. So the colours show the beams. These are different beams here. There are mountains and valleys within each actual beam which allow you to essentially generate any shape contour that you wish. Here's an example of an oropharyngeal cancer. With a corresponding PET. It also shows a small node there. On the IMRT treatment field here, the key things to note are that the dose is sculpted. So the dose is sculpted to the areas that you want the dose, and it misses the key areas of normal tissue that are to be missed. And the key one, normal tissues to miss, the parotid glands because of the high morbidity of including them in high-dose radiotherapy for head and neck cancer, and also the spinal cord. So there's almost no dose to spinal cord here and little dose at all to parotids. And so that's the whole value of modern IMRT radiotherapy in a nutshell for head and neck cancer. There are variations of IMRT. VMAT is a type of rotational IMRT. Tomotherapy is a helical type of IMRT. And proton therapy is, again, also possible to use to get a conformal dose distribution. And there's a proton therapy facility being built in South Australia at the moment. And just to round off the types of radiotherapy for head and neck cancer, particularly in Southeast Asia where nasopharyngeal cancer is very common, brachytherapy is often used. And in France and other European countries over the years, there's been a lot of use of interstitial radiotherapy. So in this anaesthetised patient here, the patient has an infiltrating type of tongue cancer, and it's treated with radiotherapy needles, and the overall outcome is often similar to surgery, perhaps slightly lower local control rates, but some good local control with that type of therapy with obvious important cosmetic and functional benefits without having resected tongues. Okay, so if we talk about target definition for head and neck cancers, historically CT has been the main method, and that's for morphology and also for the electron density dose calculation for radiotherapy. The other traditional method of structural imaging is MRI, and then there's also PET scanning. So if we think of the role of radiotherapy treatment planning and PET in that process, the first could be the delineation of the primary tumour volume, or the GTV that we mentioned before, and the localisation of the GTV. The second is for delineation of loco-regionally involved lymph nodes, and then there are lesser contributions also, perhaps by reducing intra and inter-observer variability in GTV definition, and also in identifying cases where radiation dose intensification may be of benefit. So looking at the GTV volume definition, this patient with a supraglottic tumour here, the structural imaging may suggest that the tumour is slightly larger than is shown on the functional imaging. And is that truly the case? So there's been a number of studies that have looked at this. And here we have on the table the available data. So you'll see that the numbers are small, but the sites involve pharynx, essentially. T stages range from T1 to 4, but it's heavily weighted towards the higher T stages, T3 and T4. And these columns here give the gross tumour volume that's been calculated according to CT, MRI or PET. And the summary down here shows that for PET scanning, there's a smaller overall GTV volume size across the board that's been obtained by using that form of imaging rather than structural imaging. So it seems that GTVs are smaller. So that's obviously very important, because what as radiation oncologists we want to see is a smaller target, because it allows reducing the amount of exposure to normal tissues and then potential morbidity from that. There might be a caveat to this particular situation, in that some base of tongue tumours can show extra spread with PET, and that might increase the PET volume. So just discussing that table, interestingly, the methods of defining the GTV in that work was different. Sometimes it was by manual delineation, sometimes by fixed SUV and other methods. Also, the smaller GTVs did translate into a smaller CTV and a smaller PTV, because you can obviously draw whatever size CTV or PTV you want, but they actually were also correspondingly smaller. There was less of an effect that was seen in smaller tumours. And how do these studies compare with the gold standard of surgery? And there were two studies that compared their data with surgery. And both of them showed that, firstly, PET had a higher accuracy in delineating the primary GTV, and there was a statistically significant reduction in target volumes and doses to surrounding tissues using FDG PET. PET may also enable a greater tailoring of fields, IMRT fields. In this particular study, there was dose escalation was possible here up to 75 Gray. So usually you'd be using 60 to 66 Gray. So up to a much higher dose in select patients using PET without any geographical nodal misses. There was an important study that correlated tumour imaging contours with resection specimens. So in this study, the authors compared GTVs that were obtained in a different fashion from structural imaging or molecular imaging, and correlated it with surgical specimens. And the outcome was that the FDG PET volumes correlated the most closely with the surgical samples. So that's also good news as far as the contribution of PET to head and neck radiotherapy planning. As has been noted at many sites, SUV can have important prognostic applications. It also seems to be the case in head and neck radiotherapy. In this particular case here, pre-radiotherapy SUV maxes were looked at compared to various clinical outcomes, and in fact there was a correlation with these clinical outcomes for pre-radiotherapy SUV max. Another study found similar results for SUVs that were looked at during radiotherapy as well, and they are predictive of tumour recurrence. And so that suggested that SUV is a prognostic marker for radiotherapy outcome in head and neck cancer, and it also raises the idea of adaptive radiotherapy based on molecular imaging. So, for example, if you had a patient that had a high SUV and the SUV dropped precipitously early on in the course of radiotherapy, that might indicate that the person might be suitable for a de-intensification process in their therapy. And that sort of investigative approach could be looked at. So next, looking at the loco-regionally involved lymph nodes and the contribution of PET to radiotherapy treatment planning in head and neck cancer. So if we look at the sensitivity and specificity of the different modalities here, sensitivity is very similar. Specificity is also rather similar, although it may be higher for FDG PET. So it seems like compared with structural imaging, there might be a similar sensitivity of PET, but perhaps improved specificity for nodal disease selection. And that suggests that overall, all the modalities might be ideally used together for radiotherapy field placement. This is also after you've used your PET for your diagnosis, so that the actual radiotherapy fields have already been determined. PET might also be useful for boosting sites of otherwise unknown disease. There's one interesting possibility is that if you had a person with a clinically negative neck and also radiologically negative neck on structural imaging, could you use PET to actually have the confidence to say, we won't be treating that neck either with radiotherapy or surgery prophylactically? Unfortunately, that doesn't appear to be the case based on a couple of meta-analyses, and so it doesn't seem like PET can add to the selection of prophylactic radiotherapy target volumes in the neck. Next factor. So it's important that you get reproducibility in your delineation of radiotherapy targets and the normal tissues that are around them. So a reduction in the GTV target volume delineation has often been shown mainly in non-small cell lung cancer. That also exists in head and neck cancer as well. So PET is good to decrease intra and inter-observer variability in contouring the GTV. The final area where PET may be of use is to identify areas where radiation dose intensification may be of benefit, and that brings up the concept of image-adapted radiotherapy. This has been looked at in two contexts. One is for hypoxia traces and also for FLT. So for image-adapted radiotherapy, the background is that most loco-regional failures in head and neck cancer occur at the site of bulk disease or FDG avidity. Hypoxia is a common feature in head and neck cancer, and it adversely affects radiotherapy response, local control, prognosis and survival. So the idea is that perhaps you can give extra dose of radiation to radiotherapy subvolumes based on molecular imaging. And that's been termed dose painting by numbers when you increase the dose of radiotherapy using IMRT to the voxels that have the highest intensity. The similar concept has been applied to FLT because accelerated tumour cell proliferation is an important mechanism of adverse outcome in head and neck cancer. So FLT is a measure of cell tumour proliferation, not as affected by inflammation as FDG. There was one small proof of concept study that had 10 oropharyngeal cancers. They found that the signal changes using FLT preceded the volumetric tumour responses, and this therefore meant that these studies were potentially suitable for early response assessment. They also found that there were tumour subvolumes that were able to be determined with high proliferative activity, potentially suitable for dose painting, as we discussed for hypoxic tumours. And so FLT could be potentially a promising PET tracer for imaging tumour cell proliferation in head and neck cancers, and potentially for dose painting them with a higher dose. Although we haven't heard more really on this theme since this time in which this was described, and so we wonder about the practical applications of these sort of technologies. It could be that there are temporal changes in proliferative regions and hypoxic regions in tumours that are making a sort of a continuous application of the different dose painting techniques difficult. So just in the last couple of slides, I'd just like to say there's a few practicalities that we should consider when we're thinking about collaborating between radiation oncology and nuclear medicine as far as getting our act together and to getting the best results for our patients. It helps to have close or co-localisation of departments. Close collaboration is very important, especially for target contouring. There should be standardised protocols and standardised image registration. PET scans should be repeated if they're not recent, that is probably within a few weeks for head and neck cancer, and also if they're required without the patient in the radiotherapy patient treatment position. Patients should be immobilised on a flat couch in the radiotherapy position using lasers and skin tattoos, thermoplastic shells and various other immobilisation devices that will be used for the radiotherapy treatment. As we heard before, there are a number of possible PET false positives in head and neck cancer, such as in lymphoid tissue, vocal cords, in areas of inflammation or infection. And again, that emphasises the value of a close collaboration between the nuclear medicine and the radiation oncology physicians. Second last slide, there are possible pitfalls in head and neck radiotherapy planning using PET. The first is non-standardisation of PET window settings that can affect the GTV volume and shape. The majority of studies to date have been small, single institution, heterogeneous, with limited follow-up. There's been little validation so far against the gold standard of surgical pathology. And as we know, all the imaging under-recognises the mucosal extent of tumours. In the future, perhaps we'll see more adaptive radiotherapy with dose painting and routine application of some of the current non-FDG traces and new traces being developed. So in summary then, as far as the contribution of PET to head and neck radiotherapy planning goes, PET-CT on average reduces radiotherapy target volumes at the primary cancer site. That's very good news. It's expected to improve the therapeutic ratio. However, we don't have any local control or survival data available as of yet. Structural and functional imaging should both be used in conjunction for radiotherapy nodal fields, and PET can be useful for boosting sites of otherwise unknown disease. And again, close cooperation between the different groups can improve outcomes. Thank you.
Many thanks, Michael. That draws the session to a conclusion. Thanks very much for everybody's attendance. Can I just remind you that the gala dinner is tomorrow night. You need your badge to get in, and on the badge there's a little icon down in the corner that says you've got a ticket. So if you don't have one, draw it in. The lunch is available in the exhibition hall, and the poster session starts at 1 p.m. Thanks very much. And thanks again to the speakers. It's great.